Good afternoon. Today, we're going to talk about a topic that's really significant in the work that we do in hospice and very significant in the work I do with what's called the African American Church Empowerment Project. And that is the impact of social determinants of health on hospice utilization. And I will talk about the Empowerment Project more at the end of this slide presentation. But what I will say about it now is that because of the impact of social determinants of health on hospice utilization, the Empowerment Project was created. But what is all of this about, right? Now I'm going to tell you a story, Karen's story. Karen was sitting in the doctor's evaluation room, not in the doctor's office, in a little evaluation cubby there, probably in the emergency room. She has received a terminal diagnosis, and the doctor tells her that she needs to eat 3 meals a day, get plenty of rest, stay warm and dry, and she needs to take her medications. Karen smiles at the doctor, says goodbye, walks out of the hospital, goes to a row of businesses on a rather busy thoroughfare. But there are businesses like coffee shops, restaurants, jewelry shops, places where you go shopping. She picks up a hefty rock and she throws that rock in a window. And then she sits down on the curb and she waits. She's actually waiting to be picked up by the police because in order to eat 3 meals a day, stay warm and dry, get plenty of rest, and to be able to take her medications, she has to be in prison. She is homeless, and that is the only way that she is going to get all of these needs, these particular needs, taken care of. Why? What are social determinants of health? And the answer to that why is social determinants of health. The conditions in which people are born, grow, live, work, and age, as well as the complex interrelated social structures and economic systems that shape these conditions. And that's a definition given to us by the Centers of Disease Control and Prevention, the WHO. Well, that's quite a mouthful. What does all of that mean? Let's see. This is an incomplete list, I must say, of the social determinants of health. Let's talk about each one for a moment. Access to health care. Karen had access to health care of a kind, but she didn't have a primary care physician of her own. She, in fact, got her health care needs met going to the emergency room or the emergency department, as we say more often now. She did not see a physician who knows her background and her medical history, who knows her and has known her over an arc of a period of time. She does not know a physician who, in fact, she trusts and whose suggestions she will follow. Karen does not have what many would consider access to health care. Education level. I don't know what was true about Karen, and Karen was a real person, by the way. This is someone I didn't know, but had heard about when I was doing an internship, working with women who were in one way or another caught in the criminal justice system. But her situation was not uncommon, of people who don't have the best of education, or if the education is in fact subpar, not up to par. If it's not education that will in the end afford her benefits based on what the knowledge that she has, what that knowledge is, how much of that knowledge she has, and how she can navigate educational experiences. If that's the case, what does it mean for employment? You don't have to have a really high level of education to get a really good job. But given Karen's situation, the possibility of her having a really good job, if in fact she's got to throw a rock in a window to get the police to arrest her, to put her in jail, if that's what she needs to get the access to the health care and all of the other amenities she needs, I would think, and you may agree with me, that employment was not easily come by for Karen. And even if she were able to find some kind of employment, the possibility might be, separate from the involvement with the criminal justice system, and that's not always true in terms of social determinants of health. This was just true in her case. If in fact you're having this much trouble with education, and if you're living in a situation where you don't have health care, it points to the fact that you probably don't have the employment that secures health care. Most people in the United States who have really good health care programs, coverage, are getting that health care coverage through employment and or Medicare, Medicaid. And if that's the case, then employment may or may not have led to that health care, and Medicare and Medicaid don't provide the same levels of health care. So here we have access to health care, education level, and employment all working together to inform how healthy Karen might be. But let's continue. Food insecurity. If in fact you are living in a situation, in a community, in an area where there are no grocery stores, where to get to the grocery store is a challenge, where you can actually access, if you get to something like a grocery store, fresh fruits, vegetables, and meats. If in fact your food security is limited, that impacts what in fact your health is like, and of course the health of your children. It informs employment, it informs education for your children, and it impacts your health. And of course, income. If you are not someone who earns a level of income that supports your needs, then you are making do without any number of what would be called determinants of health. If you don't have the income you need to help with that education for your children. And let's go to the next line. If you don't have the income you need, and don't have the access to health care that you need, then what does that say about mental health as well? And you don't have access to other things coming on this list. Health care, appropriate education, a good job that pays a good income, food insecurity, and you're struggling with mental health issues, all of those go together to impact your health. Race and ethnicity. Historically, it's been proven that certain racial groups, certain ethnic groups have poorer access to health care, may in fact have poorer access to good quality education, have poorer access to employment that would support a family and provide the determinants of health. And next comes safe housing. If in fact you are living in a situation where you don't have the funds to actually buy or rent even housing that is stable, safe, and that protects you and your family, then you are under stress. Children are probably not exposed to a safe environment for learning, for playing. Again, you are struggling with the determinants, the social determinants of health. Social supports. COVID-19 just taught us that there are many, many seniors, for example, who don't have social supports. During COVID-19, some of these seniors who didn't have social supports that, like social technology, like being able to reach out to friends and family using technology, and even as important, social systems, community support systems that actually make it possible for them to feel cared for, protected, engaged with others. And if that is not in place, even if some of the other positive social determinants of health are in place, we've learned, research has shown, we've learned that people do suffer and in fact struggle with mental health issues. Let's keep going. Transportation. I lived a year in Boston, Massachusetts, or in a suburb of Boston, Massachusetts. Boston was a wonderful city for walking to get to where you wanted to get to or using public transportation. What if that public transportation had not been available and you lived in a community like where we are living, where public transportation is limited, and you have an impact on your ability to sustain transportation because of your income, and that's because of your employment, and that's because of the education level you have actually achieved and gotten up to, and all these other social determinants of health are impacting whether or not you can sustain transportation. I think you get the picture. Let's keep going. What does it mean? Let's look at a scenario. You have a single mother, 2 small children, and mom has 2 part-time jobs, maybe because of education, maybe because of the limitations that she is bound by. because there's no health care benefit there. So maybe she's not able to keep her own health in a positive light. Maybe she's just not healthy herself, and maybe she's not able to maintain the health of her children. 2/3 of her salary is used on housing. She has to maintain a car for work for these 2 part-time jobs. If she has any trouble with her car, she can't get to work. And she's relying on her mother for childcare. What's the neighborhood like? There's no grocery store. There are no green spaces for her children to play in. And even if there were green spaces, the possibility is, given the situation she's having to live in, the community may be a violent community, which means the children can't go outside to play. This equals a high level of social vulnerability. And that means that she's struggling to maintain a high level of social determinants of health. As her children grow up, their education is subpar. Finding food is difficult. Healthy fruits, vegetables, and meat. Finding food is a problem. So there is food insecurity. The lack of consistent health care means that she and her children are struggling, especially since they're struggling with food insecurity. They're struggling to maintain their health. The possibility is also there that their limited access to technology and science education actually calls into question whether Karen can get a high school diploma, or if she does, if she can go on to college. It also calls into question what's possible for the children. Limited social supports, whatever they might be, and however they might be limited, means that there might be some isolation in this circumstance. And there is the safety issue. Are the children getting enough exercise? Can they go out to play? If they go out to play, or if they go out to go to school, or if they go out to do any number of things, are they safe? The employment options are limited, made that much more limited if something happens to transportation. And this family, looking at all of these factors that impact their lives, this family will probably remain in this community. So getting out of the circumstances, getting above and beyond the circumstances, and being able to live a life that's very different from these circumstances, that can be hard to do. Keep in mind that these social determinants of health, again, can happen in an urban area. It can happen in a suburban area. This can happen in a rural area. So there are no safe places. It can happen in an affluent area. I know of some communities, some wealthy communities, where people are spending, just like Karen in our case, spending 2/3 of their income on the housing that they want to maintain a facade of success, and they're eating hot dogs every night. And part of that may be because of lack of access to health care. We don't know. The National Center for HIV, Viral Hepatitis, STD, and TB indicate that social determinants of health are linked to a lack of opportunity and to a lack of resources to protect, improve, and maintain health. These factors are mostly responsible for health inequities, the unfair and avoidable difference in health status when seen within and between populations. That being the case, unequal access to hospital care and lower health insurance rates drive racial differences in mortality. And here's a bit of research, as you see on the screen, to support this statement. When there is unequal access to hospital care and lower health insurance rates, that means that some of these social determinants of health are not being supported, are not present for a given family situation. And again, COVID-19 pointed to this unequal access to hospital care and lower health insurance rates as the numbers of people who were African-American, Black and Brown, living in Detroit were not able to access what they needed in order to protect themselves in some cases from the virus. One thing, for example, was often the vaccine was made available at CVS. What if there is no CVS in the community, or there are limited numbers of CVS in the community, and transportation is not available to help them get to a CVS to get inoculated? What about then? Mom becomes ill, Karen becomes ill. Her symptoms are long-standing and there's no health insurance, there's no primary health provider. The symptoms worsen and back into the ED she goes. She still does not have a primary care physician. She still does not have anyone available who understands the arc of her health history. She still does not know anyone who might work with her, whom she trusts. She's tested. She receives a late-stage cancer diagnosis during that ED visit. And do they come to her and talk to her about hospice? Maybe. Maybe not. That is another piece of this issue, that without a primary care physician with whom someone has a relationship, it's often the case that the wide array of options are not presented to the person in question, and they don't get the information they need to actually make an informed decision. In that case, they hear the word hospice, someone tries to explain to them what it is, and fear immediately rises to the surface. You mean you're not going to take care of me? You're not going to make me better? You're not going to heal what's wrong? You mean you're going to let me die and you're going to provide services to me as I am dying? I don't want that. Unfamiliar with hospice, she declines the care. Where social vulnerability exists, the odds of hospice utilization, early hospice initiation are reduced. Just think, she didn't get that diagnosis until she was quite a bit along the road to death. And so the diagnosis came late, and she couldn't access, even if she'd chosen hospice, she couldn't access hospice given the late diagnosis early enough to benefit from it in the ways that we like to provide hospice care. Non-medical considerations also include education, food insecurity, questionable and unsafe housing, unreliable transportation. Poverty negatively impacts both health and hospice outcomes. So all of these social determinants of health impact health, and they impact hospice outcomes. The conclusion: social vulnerability more pronounced with minority patients because they don't get the information, because they may not trust the information, because there are so many determinants of health that impact their lives before they need to make a decision about hospice, that whether or not they get the care is informed by all of those social determinants of health that are unmet. Having a home, a regular income, and social supports means that you are most likely destined for a dignified death. How do you treat a terminally ill patient's pain or nausea when they can't afford medication? So if a patient is deciding, do I pay for keeping the lights on? Do I pay to keep a roof over my head? Do I pay for transportation because I'm going to need that no matter what? Do I pay for those things, or do I pay for this medication and remain isolated? A hard decision to make, and a decision that many people struggling in these ways have to make all the time. Now, one suggestion that was on the screen when I first came up with this slide presentation, and this is something that has been put into effect in many communities, is community health workers who are frontline public health workers who actually stay in touch with people in insecure communities, in communities where people are struggling with actually securing and maintaining these social determinants of health. These public health workers go out and keep tabs on people in the community, helping to make sure that they are safe, that they have some socialization, and that they, if need be, have access to health care. These community health workers are trusted community resources who facilitate access to services. And because they are engaged with people in the community, they help to improve quality and cultural competency. So they help improve what is normally considered communication and interaction with a cultural group. They come from the community. They are able to speak the language, whatever the language is. They are understood, and that's understood in the broad sense of the word. And again, they are trusted. And they then help to bring people in need of services to the services they need, or bring the services that are needed to the people who need them. So what can be done? These services provide outreach, which includes education, informal counseling, and social support, advocacy, which includes translation and interpreting when necessary, healthcare navigation, and tracking progress to make sure, this is advocacy that makes sure that people are followed up with, are reminded of appointments, are checked in with to determine how they're doing with whatever their instructions were. And they provide support for mental health. Again, that socialization. The community empowerment projects are also available. Services providing education, advocacy, and practical training. So this was something that actually started shortly before, but really started and got going during the pandemic. And so there are some communities that are benefiting from this kind of support. But now I want to tell you about the African American Church Empowerment Project. And I'm going to check the time because I want to leave time for questions, but I also want you to understand why the project was started here at Angela Hospice and what it does in the community. Once, I think maybe 10 years ago, there was a young man who was getting his PhD in philosophy and ethics, and he chaired the ethics committee here at Angela Hospice. At the end of a meeting, an ethics committee meeting, he said to some of the members of the committee, he was in conversation and said, because you know, African Americans are underserved by hospice care. And there were people at that ethics committee meeting who did not know this information. So they decided they wanted to find out why this was true. They said, that doesn't sound right. Something's wrong. That can't be true. There has to be an answer to how that can be reversed. They did their research. They found that statistically speaking, African Americans were underserved by hospice. And they found the reasons for that. Some of it was education, and some of it was the social determinants of health in various forms. There was a high level of mistrust for the healthcare community, given the history that African Americans have experienced in this country, including around receiving healthcare, and in some cases, being taken advantage of in terms of research around receiving health care. And so there were people who just were not willing to leave the end of their life in the hands of people who were not going to actively engage in trying to cure them, but were going to let go and just provide comfort care. People heard hospice, they thought death. And mind you, this is something people think about in terms of hospice across the board, whether the social determinants of health are in fact robust and in place or lacking. The team here decided that they wanted to reach out in the community and find people who might help them come up with a feasibility study, to check with them to get a better sense on the ground about how to reach out to the African American community and inform the community about hospice care. When they did that, they came up with a slide presentation, much like the one I'm doing today, but quite different because it focused on hospice and what hospice provides, the services that are being provided, including information about palliative care, which is further upstream from hospice, so people could start getting support before hospice was necessary, all the way to bereavement care, and just how people might be supported after a death occurs, and that support for the family. When people who were gathered from all walks of life, whether it was healthcare, higher education, faith communities, seniors communities and seniors facilities, people who were in leadership in faith communities, as well as people from the pews. When they came together, were brought together by people here at Angela Hospice, and they were shown this slide presentation that fully explained what was available with hospice. They asked, would people you'd like to, would they be interested in this information? Is this information you would want them to have? And everyone sitting at the table gave a resounding yes. And they asked, how can we get this information to people? And they said, do that through the churches. So the plan was to contact the leadership of churches and ultimately other faith communities, have them select people within their ranks, people who were members of the church, who might best qualify as the people who could be advocates in the faith community, in the church, about hospice, train them about hospice, and give them a certificate at the end of the training showing that they'd gone through the training, and then introduce them to the congregation or to the faith community, and let people see who has information about hospice and end-of-life care, and have those people actually be advocates, not for Angela Hospice, but for hospice. We have reached to date between 15 and 20,000 people. That is, we've trained people in between 13 and 15 churches, and those people impact that many people in their communities, not to mention their families and friend groups and other social groups. So that is what we are doing, trying to provide education. But keep in mind, as you think about hospice, as you think about, and I'm going to stop sharing now, as you think about hospice and you think about those social determinants of health, and as you think about healthcare in general, keep in mind that people who are struggling, people who have a variety of limitations on their lives, they are struggling at the end of life as well. Thank you so much. I think we have a few minutes for questions. If there are any, I'm happy to entertain them. And if there are people who can be on the screen, I'd be happy to see you.
Hi, Diane. Thank you so much for your presentation.
Thank you, Lisa.
It's always great to hear from you. You've got so much insight. I know that I had a question. When it comes to if someone identifies themselves that they might be in a vulnerable position because of the social determinants of health,
yes,
what would be a good action step for them to take in order to, make sure they are getting the resources they need?
If they self-identify?
Yeah.
I think actually, if they have access to technology, if they have that access to actually do some of their own research and figure out how they might get the services that they need. It's often the case, however, that they don't, if they have the access to the resources, let's say the tech accesses, it's the other social determinants of health that may determine whether or not they can take advantage of the information they've learned. But I think being able, if they have a resource, a technology resource, finding resources is always a good way to find services, to connect with other people, to ask questions in community if they have that technology.
Thank you, Diane. Another question that came in is, are these social determinants of health, is that something that is taught about in medical school? So would medical professionals have training to look for that or to be aware of how that might be affecting someone's care?
Actually, it's not very common that people learn about the social determinants of health in medical school, which is a reason to actually present this kind of programming here for hospice employees, to have it available to help people think about these things, because people don't normally think about this kind of thing. But it's not a course in medical school, no. In fact, I will be talking with some women next week who are in medical school, who are interested in working with underserved communities. And they are needing this kind of information before they try to reach out to people in those communities. So it is not the common education that people get in medical school, no. Someone has to generally have an interest and pursue
Right.
it themselves.
Okay, that's very interesting. Um, I was wondering if you wanted to speak at all about the Good Samaritan care that Angela Hospice provides.
Sure, I can do that. What I tell people during orientation is that if they, and this is people mostly in the field, not people already in the care center, of course, but people in the field, team members in the field, if they are aware that a patient is at home, or in a nursing home becomes a little complicated, but let's stick with at home. If they are at home, the family's doing the very best they can to care for the patient, but the patient needs a little more support, a little more care. And the team members, one team member can bring this idea back to the rest of the team members, and the team members can confer about the case, and they agree that this would be someone who would benefit from being able to be cared for either in the care center here, or in sometimes we might handle having them go to a nursing home and cover those charges. But the bottom line is we can bring this information back to Angela Hospice. The team agrees, and they in fact refer the patient, give the information to Marty, who reviews the information about the patient's care and makes a determination about whether or not this is a patient who qualifies for coming to the care center or going into a nursing home and having us cover the costs. So this would be someone who would not be able to cover the costs themselves. Do people stand in line waiting to take advantage of the Good Samaritan Fund? No. If people are at home, they generally want to be at home, wherever home is. So you might think that people would really rush out to take advantage of this offering, but that's not the case. And so we are very happy to provide that support, very happy to be of assistance as it's needed. But when it comes to the social determinants of health, the question is not if they're on the if they are on hospice care, what can be done. The question is how to get them to the hospice care as quickly, as soon as possible, so that they can take advantage of the services that we provide.
Right, right. Well, I know we've been able to share some stories about the impact of the Good Samaritan program and
Yeah,
the impact of the empowerment project that you mentioned. So maybe we can link those along with this video. Um,
okay.
well, I want to thank you. I know it's just almost 2 o'clock now. It looks like
Yes,
about time to wrap up. So thank everybody for joining us, and thank you, Diane, for presenting. This was great, very informative, and hopefully everyone can join us in person for our next Angela Cares speaker series. That will be August 16th with Deacon Jenny Ritter, who will be sharing Preparing the Spirit. It should be a great presentation and wonderful to all be able to meet in person here at Angela Hospice for that.
Good.
So we're looking forward to it, and thank you all, and I hope everyone has a blessed day, enjoys the beautiful sunshine.
Thanks, everybody. Thanks for coming. Bye-bye.